All right, so respiratory emergencies. All right, I've been talking about this. I've been slowly introducing a lot of these terms as we have gone along. When we talk about rails, crackles, rhonchi, stridor, so on and so forth, wheezing, we're going to talk about all of that. Lower, upper airway. Okay, I'm not going to talk about this too much. All right, but we are going to talk about some conditions that are specific to each. When auscultating the chest, okay, we know exactly what we're going to auscultate. Just looking at this guy, what condition do you think this guy has? COPD. Why? This slide is probably a little easier. That barrel chest. Okay, just looking at this guy, I'm going to suspect COPD. All right, excellent. All right, so we're gonna auscultate our patients. All right, so when we're assessing breath sounds, all right, we may have wheezing. Wheezing is what? Upper or lower airway? Lower. What is wheezing? It's a construction of the bronchioles. Awesome. All right, rhonchi, and then crackles, also known as what? Rails. Crackles is also known as rails. Okay, what is rails? What's happening? The alveoli are popping open on inhalation or exhalation? On inhalation. As you inhale, they are popping open. Okay, they are popping open at that time. Hypoxemia is different from hypoxia. Hypoxemia is what? Low blood in the low oxygen in the bloodstream. Okay, low oxygen in the bloodstream. What is hypoxia? That's decreased oxygen in our cells. Okay, at our cells, at a cellular level. Hypercarbia, okay, that's increased carbon in our bloodstream. So, let's talk about our COPD patients real quick. What is their SpO2 going to look like? Normal? It's gonna be pretty low. It could be in the 80s. Is that normal for them? Yes, that is normal for them. Why is that normal for them? Because they what? Because they have a hypoxic drive. What does that mean? What is a hypoxic drive? So for our COPD patients, okay, the chronic emphysema, so on and so forth, those types of patients have a hypoxic drive. When their oxygen levels get too low, that's when their brain kicks in and says, hey, take a breath, dummy. For the rest of us, we have a hypercapnic drive. What does that mean? That means when we have a buildup of carbon monoxide in our bloodstream, that's when our brain kicks in. So all of us that don't have COPD, we have a hypercapnic drive. That is the norm. That is the norm. But our COPD patients have a hypoxic drive. Awesome. Good memory on that one. All right, so some common complaints when we get to respiratory distress. Dyspnea, what is that known as? Shortness of breath or just difficulty breathing. Apnea is what? The arrest. They are not breathing anymore. Okay, they may be restless or have anxiety, decreased in change in pulse rate. It's probably going to be what? Up or down? In patients with respiratory distress. Up. Why? Because the body's trying to maintain and compensate for the problem that's having. So it's going to say, all right, so we need to, what are our blood vessels going to do? They're going to constrict. So our blood pressure is going to do what? Our blood pressure is going to elevate. Our respiratory rate is going to elevate. Okay, those are all things that we see in respiratory distress. We may see a change in skin color. Okay, they may be pale. They have pallor, or they may be cyanotic. Okay, which is a later finding, the bluish tinting of the skin. All right, we just talked about this. So we might see a narrowing of the bronchioles. Okay, from inflammation or swelling. Okay, it could be due to what? Why might we see a constriction in the bronchioles? Asthma, anaphylaxis. All right, it could be due to a injury to the neck, head, face, spine, chest, abdomen. Okay, cardiac compromise or hyperventilation. Okay, Someone having an anxiety attack. Old school, used to be told what? What to do with a paper bag? Blow into it. Why? What was the thought behind that? Anybody know? They thought that you would be exhaling the carbon dioxide, too much of it, so you just inhale that right back. Okay, so you'd try to kick in that hypercapnic drive, and you hopefully regulate. We don't do that. Okay, just slap oxygen on them. All right, so there may be a dysfunction of the respiratory airway, so there may be a mechanical disruption. Right, we're going to talk about those later. There may be inadequate gas exchange. So let's say someone has pneumonia. What is a characteristic of pneumonia? What is pneumonia? Fluid in the lungs. Okay, and because of gravity, what lobes is that going to sit in? The lower lobes. So they are going to be surrounded by water. All right, so that gas exchange, or I say water, surrounded by fluid, so that gas exchange might not be very good. All right, drownings are another reason why you might have excess fluid in the lungs. All right, so disturbances may be categorized in one of three ways. Respiratory distress, and we're going to talk about these in a second when we talk about failure and so on and so forth. Respiratory distress, all right, we want to consider a CPAP. These patients are probably going to be tired. Okay, they're probably going to be tired, and slapping a non-rebreather might not be enough. So these patients may need a CPAP to force air into their bodies and just kind of help them along. But if we're moving into respiratory failure, okay, a CPAP is probably going to be your go-to device here, if not using a BVM to force breathing into them. So when it says failure, okay, take this with a grain of salt. When we say CPAP, they may be leading towards failure. A CPAP might be able to prevent them out of this. But if they are absolutely in respiratory failure, they have inadequate ventilations, we're going to have to breathe for them. That means we're going to have to provide PPV, so a bag valve mask, we're going to have to ventilate for them. And then absolute respiratory arrest. So it goes from distress, failure, to arrest. This is where they're not breathing anymore. This is where we absolutely have to breathe for them using a BVM. Because respiratory arrest is going to lead to cardiac arrest if you don't do something about it. All right, so here's some reasons. We talked about COPD, emphysema, and chronic bronchitis. What is a habit that we see in patients that have COPD? Most often, smoking. Okay, most oftentimes it leads to smoking leads to COPD, emphysema, chronic bronchitis, because we get a buildup of gunk in those bronchioles. Okay, so we get a buildup of gunk, and here you see it in this photo. So they become obstructed. That obstruction is where we get the obstructive in COPD. So we get a buildup of mucus in the bronchioles. We also get decreased surface area in the alveoli. So they can't perform their job as well. So when we're talking about emphysema, all right, so let's, PEEP. Did he talk about PEEP and what PEEP is? All right, PEEP is positive end expiratory pressure. I added this into the slide because it just mentions PEEP, but doesn't explain what it is. So what is PEEP? All right, so that's the definition, but that doesn't really tell us what PEEP is. Okay, so PEEP is where we're trying to provide additional pressure to keep our lungs open. Okay, so PEEP is the pressure above atmospheric pressure that remains in the lungs at the end of exhalation. So your patients might purse their lips. They might purse their lips, trying to keep an adequate pressure in their lungs, keeping their airways open, keeping everything open. Did you break it?
Yep.
It happens. All right, emphysema. All right, emphysema. We're still talking about it. Okay, so many signs and symptoms of emphysema are similar to those listed in respiratory distress. So you might see this. The patient's in what? What do we call that? Tripod position. Look at his neck. I know it's very difficult, but what do you see about his neck? Jugular vein distension. So he's probably got a lot of conditions going on. What is one condition we might see JVD with? Congestive heart failure. Awesome. And you listen to the side of the heart. So, and we're doing our seeing size up. I see this guy. I see he's got JVD going on, so I might suspect CHF. He's in a tripod position. But what else do I see? I see cigarettes and I see cigarette. Okay, and he's still smoking it. Okay, because he put it in the holder and he didn't knock out the butt. So he was just recently smoking. So this guy, what would you do for him? How would you administer oxygen in this guy? Probably a little more than that. A CPAP. A CPAP. Why would I do a CPAP? Well, if he meets the criteria, so able to sit upright, alert and oriented, okay, so his blood pressure is really the only thing I'm worried about here, okay, but CHF, all right, so I suspect CHF because of the JVD going on, so CPAP would probably be very good for him. Boom, CPAP, or BiPAP if necessary.
Don't you have to worry about collapsing the lung and people with COPD like that when you give them CPAP for too long?
Not really, not really. And okay, so you know what? Great question. So, so people get a little skittish when about giving COPD patients oxygen. Here's the reality: if they need oxygen, they need oxygen. If they're showing all the signs and symptoms of respiratory distress leading into failure. Okay, I'm going to give them oxygen. I'll be damned what the SpO2 reader says, because I don't care. I need to give them oxygen. I'm going to get oxygen in their body. The hospital can figure it out at the other end. Okay, I'm not going to be just kind of tiptoeing around it like, well, maybe I should give them a non-rebreather and maybe titrate it down. No, I'm going to give them oxygen, especially if they're showing signs and symptoms of respiratory failure, that cyanosis especially. Okay, or if they're just tired and they're just acting so tired, like this guy right here, he is struggling for air. Okay, whatever was going on with him is not enough. I need to give him something a little more than a nasal cannula. So COPD, chronic bronchitis, what's going on? That's swelling or thickening of the bronchi or bronchioles. Okay, the lining is full of mucus plugs. The alveoli remain unaffected by the disease, but it is associated with smoking. We see this a lot in chronic bronchitis. The narrowed bronchioles reduce airflow, not blood flow, and the reduced lung ventilation with increased lung perfusion. We might see what we call an incentive spirometer with these patients. They might have one that they're told to breathe in fairly often to just see how well they're doing. Like I said, I'm not going to go too much more into this. I really wanted to talk about COPD here. So we're not going to go through all 42 slides. We're going to talk a little bit more. Asthma. What's the medication we might give these guys? Albuterol. How much? 2.5 what? Milligrams. How do we administer it? Small volume nebulizer. Okay. So because they may be having a bronchospasm, I'm going to give them albuterol because it's going to do what? It's going to dilate the bronchioles. Okay. So you might see this term either on your exams or on your national registry when we talk about a beta-2 agonist. A beta-2 agonist. Albuterol is a beta-2 agonist. All right? There's a good chance you're going to see that term in the near future when we're talking about what is a beta-2 agonist. Okay? Albuterol is one of those. I'm not going to go into the what is a beta-2 agonist, but just know that albuterol is one of them. There might be other medications that your medical director allows you to give, especially somebody that's having a condition like this. It might. Have you ever heard of an A treatment? Albuterol and Atrovent. Okay, Atrovent is used to help clear up like the mucus and all that. So that might be a medication that your job allows you to use. Huh? Is epinephrine a beta 2?
Yeah, but it helps everything. That's why he said it's like
It
helps heart.
it is a beta 2 agonist.
I didn't say it was. I just said I think it's multiple things.
Yeah, it does. Yes, it does more than just that. It does quite a bit more. But yes, epinephrine is also considered a beta 2 agonist. All right, so this one I'm cutting it short. I know if anybody's listening to this for study hall because you're watching it on the YouTube, we're cutting short because we've already been going for about 2 hours at this point. So we're going to stop right here. And if you need to, continue to review these slides. If you have any questions, you can email me at sseagroves@mclennan.edu. Otherwise, hope you do well on your test tomorrow.